Hi, good afternoon, everyone.
Good afternoon, Dr. Lowe.
Good afternoon.
I think before we get started, I think we're waiting for Anastasia's here. Great. Anastasia, thank you for coming. You're muted. All right, for all the attendees, if you can hear me, we'll get started in just a couple minutes. We're still waiting for all our panelists to arrive. Anastasia, are you able to hear me?
Yes, thank you.
Great. All right, well, why don't we go ahead and get started? Good afternoon to our Contra Costa Health Plan Provider Network. We're very excited to have you join us today for our first dual special needs plan provider town hall. We're holding two sessions. One will be in about a week or so. They're essentially the same, and we just wanted to be very mindful of our providers' time. So this one is obviously scheduled for the lunch break. Please eat if you need to eat lunch between clinics. And then also the other one is at the end of the day. So if for some reason you're unable to attend this whole thing, please feel free to join the next one. We have Anastasia Dodson here from the Department of Healthcare Services, DHCS, to really give us the meat of the matter when it comes to dual special needs plan. And then we have a panel of Contra Costa Health Plan leadership to help provide a little bit more color to what we will be doing at Contra Costa Health Plan with respect to the dual special needs plan. Just for a matter of time, I'm going to turn it over to the next slide. Great. I'll turn it over to Anastasia.
Thank you so much, Irene, and really glad to be with all of you as you eat your lunch, or I know you've got many busy schedules. So I'm here from the California Department of Healthcare Services to talk about the expansion of Medi-Medi plans or D-SNPs for people who are dually eligible for Medicare and Medi-Cal. Let's go to the next slide. So 3 topics. 1, people who are dually eligible for Medicare and Medi-Cal. The next is about what we're calling Medi-Medi plans and what they are and where they'll be. And then the third is some practical tips on what you can expect and things you might want to consider, including when you're talking to patients. Next slide. Okay, next slide. So some people have both Medicare and Medi-Cal, and they are known as people who are dually eligible. Sometimes they're called Medi-Medis, but sometimes that's reserved for even a kind of a subset of that group. But regardless, for this population, Medicare covers doctor visits, hospital stays, labs, prescription drugs, and other benefits. And then Medi-Cal covers their Part B premiums, copays, and then things like adult day health care, dental, IHSS that are not covered by Medicare, and also skilled nursing facility care long-term is covered by Medi-Cal, and then some short-term stays are covered by Medicare. But these two programs do work together, but they are in fact separate programs. Next slide. So people who have both Medicare and Medi-Cal, they are low income because they have Medi-Cal, and then they are either older adults or people with disabilities. So that's how they get Medicare. And people who have both sets of benefits are more likely than people with Medicare only to report being in poor health. They have higher rates of many different chronic conditions like heart disease, hypertension, depression, dementia, and many other conditions. They're much higher prevalence among people who are dual eligibles. They also have high utilization of many services. And you can see at the bottom, when we think about our Medi-Cal IHSS in-home supportive services, over 75% of those folks are dually eligible. And then long-term skilled nursing facility residents with Medi-Cal, 80% of them are dually eligible. The two other things I'll flag about people who are dually eligible, about 1/4 are under the age of 65, and those tend to be people with significant mental illness, serious mental illness, schizophrenia, psychosis, or it could be a long-term disability from childhood or car accident, etc. And the other thing is about 1/3 statewide of people who are dually eligible have limited English proficiency. So anyway, that's the table setting that we're going to do, but they're really quite a diverse group. Next slide. So there are 1.7 million people in California that have both Medicare and Medi-Cal. And of that 1.7 million statewide, about half are in some type of Medicare Advantage plan. That includes integrated plans. And then half are in original or fee-for-service Medicare. So that's where their Medicare delivery system is. But then on the Medi-Cal side, all dual eligibles are enrolled in Medi-Cal managed care plans. So again, there's two different programs. On the Medicare side, they have various options and they can be in original Medicare or a plan. But on the Medi-Cal side, they must be enrolled in a Medi-Cal managed care plan. All right, next slide. So this just kind of gives you more details and a snapshot of the different Medicare delivery systems statewide where dual eligibles are enrolled. About half are in original Medicare, as I said, and then about 19% statewide are in what we're going to call Medi-Medi plans, a type of dual eligible special needs plans. So the takeaway here is that this is not a kind of new program in Contra Costa. It may be somewhat new in Contra Costa, but it's not new statewide. We have many years of experience with these type of health plans, and it's also a national model. But again, already statewide, 19% of dual eligibles are in Medi-Medi plans. There's also a fair number in regular Medicare Advantage plans, and then other types of special needs plans, plus PACE. Next slide. And again, that's their Medicare delivery system, but all duals are in Medi-Cal managed care. Contra Costa County is roughly 39,000 dual eligibles, and about 13,000 were in some type of Medicare Advantage, including D-SNPs in January. So that's not the same as 50% like we saw on the other slide, but again, that 50% is a statewide average, and you can see less than 50% of duals are in some type of Medicare Advantage, and more than half are in original or fee-for-service Medicare. Next slide. Okay, so let's talk about Medi-Medi plans. Next slide. So again, these two separate programs, two different funding streams, etc., they can be confusing and hard to navigate, and also it may not provide person-centered services. We've got a lot of exciting things going on in CalAIM for Medi-Cal, and some of those policies apply to dual eligibles. So again, it gets the more we put into Medi-Cal, and then the more what's happening in Medicare, the more complicated it can be for the programs to work together. So as part of CalAIM, we have a policy to require all of our Medi-Cal plans to newly operate a D-SNP, which is a type of Medicare Advantage plan, so that there's one health plan organization that can see across both Medicare and Medi-Cal and administer both sets of benefits. And that's what we call the Medi-Medi plans. So the same organization administers and has a contract to have a network, etc., on the Medicare and the Medi-Cal side. This model is already currently available in 12 counties this year and for the last few years. And you can see those counties are in the Central Valley, but also in the Bay Area, Santa Clara, San Mateo, and then Southern California, LA, Orange, Riverside, San Bernardino, San Diego. So that type of plan is going to be expanded to additional counties January 1st, 2026. Coming up. Next slide. So this is looking under the hood just a little bit. again, Medi plans, they're a type of Medicare Advantage plan in California, and they're only available to dual eligible members. And Medi plans, that's the kind of generic name that we use in California for these types of plans. We use it at the state level, but each health plan, like Contra Costa, they will have their own specific plan name that they will use. So just looking under the hood, there's a D-SNP contract that the health plan has with the federal government, with Medicare, and there's a Medi-Cal contract that that same organization has with the state, DHCS for Medi-Cal. So technically 2 separate contracts, 2 separate programs, but for the member, they're one health plan. And we'll talk about this in the next slide, but there's one phone number, one care coordinator, one health plan experience. And again, the members who are enrolled in these plans, they still get all their Medicare benefits and all their Medi-Cal benefits, but it is through a combined health plan. The last thing I want to emphasize, enrollment for dual eligibles in these Medi plans is voluntary. So they have to enroll in a Medi-Cal managed care plan, but they do not have to enroll in a Medi plan. Just like any other type of Medicare plan, enrollment is voluntary. Okay, next slide. So we use the name Medi plan or Medicare Medi-Cal plan. That's the generic term we use at DHCS, but each health plan that has a Medi plan, they use their own marketing name in the plan-specific member materials. And there are actually restrictions on what they can use and share and say in, to members before the Medicare open enrollment period that's coming up in a few months. But anyway, the bottom line is these plans are a single plan in the member-facing materials. The members get one card, one welcome packet. They have one phone number for member services. We're going to talk about they have one care coordinator across both sets of benefits, and they also have an integrated appeals and grievance process at the plan level. We have a lot of fact sheets and materials and information on our website with the links, and these slides will go out later. Next slide. So this just tells you where those Medi plans are currently. In orange, you can see Southern California, some counties in the Central Valley, plus Santa Clara and San Mateo. And then that dark blue, those are the counties where Medi plans will be newly available in 2026. And you can see Contra Costa is there in dark blue. And then the polka dot is where there'll be at least one plan, and then the lighter medium blue that's will be phased in later. Next slide. Okay, this slide is meant to emphasize the care coordination that the Medi plans need to do across all the different benefits that are covered across Medicare and Medi-Cal. So, of course, physician services, hospitals, prescription drugs, labs and x-rays, important Medicare benefits the plan is responsible for through its contracted network. But then transportation, durable medical equipment, long-term services and supports, nursing home care, that's normally split across Medicare and Medi-Cal, and the person might be in a couple different delivery systems, but that's, again, the plan is responsible for coordinating all Medicare and Medi-Cal benefits, even those that are carved out, and we'll talk about that in a sec. But one example is dental. Medi-Cal dental has a robust benefit, but the health plan, even though they're not capitated, they don't get paid for Medi-Cal dental, they are still responsible for coordinating the dental benefits for the members. One last thing I want to mention, you may have heard of Medi-Cal Enhanced Care Management. So Medi plans, they have care coordination requirements from the federal government that are very similar to ECM. So what we have done is, for technical clarification, if someone is in a Medi plan, they can get California Integrated Care Management, sorry, another acronym, CICM, but that means that they still get that robust care coordination that they might with ECM, but it's called CICM, and it's more often administered through the health plan because, again, dual eligibles have a high number of chronic conditions. And we will talk about that more in a future slide. Next slide. Okay, so again, we talked about these carved out benefits. Some of the key benefits that are carved out that are not directly funded for this Medi plan, but they still need to be engaged in are IHSS, in-home supportive services. That's administered by the county. And again, the county still determines authorized hours and eligibility for IHSS. And the members, they are the ones who decide their IHSS providers, hiring, firing, managing their providers. So there's no impact to IHSS, except that we do require that the health plan, we give them data. We want them to know which of their members have IHSS. And then if there's a inpatient stay, a hospitalization, discharge planning, to connect with the county to make sure that member can successfully transition home, doesn't have a readmission, etc. Dental, we talked about, also county mental health and substance use disorder services. Most of the behavioral health services for duals is covered by Medicare. So again, that the health plan administers the contracts with providers for behavioral health for duals, but there are some benefits that are covered by the county and not Medicare. So we want coordination there. Next slide. Okay, so community supports, you've probably heard of that. And those are available to people who are dually eligible, just like all other Medi-Cal members. And there's no difference. People who are enrolled in a Medi plan, they can still receive those community supports. If they're in a Medi plan, if they're not, because they're administered through the Medi-Cal side of the house. And again, for enhanced care management, it's similar. We have a CICM program. And again, the care management is required. It's a very firm requirement from the federal government and from DHCS that members in these plans get care coordination. And so we have a CICM instead of ECM. Next slide. Okay, great. So provider network, that is a really important function that these Medi plans have, and it's monitored by the federal government, by Medicare. Members have a Medicare provider network for all their Medicare benefits. So of course, physicians, hospitals, labs, pharmacies, etc. But one thing we like to emphasize is we want continuity of care. So if someone is new to the plan, they're joining the plan, and they have a physician that they're working with that's not in that Medi plans network, we first of all, want the plans to have a robust network, which they do. They will. They're required by CMS. But also, if that provider is not yet in the network, we will encourage the health plan and the provider to work together and maybe have a temporary agreement up to 12 months. And, hopefully then that provider will join that health plan's network. One other thing I want to emphasize is, it's not on the slide, but related. There's a federal eligibility requirement that people who are dually eligible, they can join a Medi plan any month of the year, and they can leave any type of Medicare Advantage plan any month of the year. So of course, we don't want people to cycle in and out of health plans month by month, but just want you to know that that option is always available. Any dual can move to original Medicare any month of the year. They don't have to wait for Medicare open enrollment, and they can join a Medi plan any month of the year. They don't have to wait for open enrollment. It's just if they want to join or leave another type of Medicare Advantage, then they do need to wait for open enrollment. Next slide. So this is a little more detail on the Medicare network adequacy requirements. This is from CMS, and they do review and monitor Medicare provider networks. I don't know if Contra Costa will have delegates or sub-networks, but just for your awareness, on the federal Medicare side, every provider that's in the network is considered to be available to the member. So, and I'll let Irene and her team speak to that if it's relevant. But there is information on Medicare Advantage network guidance on the CMS website, and CMS does have a process if there's any concerns about Medicare network access and adequacy. And there's also the 1-800 Medicare number. Next slide. Crossover billing is a topic that many providers are interested in. So as you know, there's a billing for Medicare, and whether that's original Medicare or Medicare Advantage. And then the crossover billing is the Medi-Cal piece, because depending on the code, Medi-Cal may pay an additional amount after Medicare pays what they will pay. So one of the benefits of having a Medi-Medi plan handle both Medicare and Medi-Cal is that they can handle the crossover billing in a more streamlined fashion. So that same organization would process the primary billing on the Medicare side and the crossover billing. Same organization, one place for providers to submit those and get their responses, remittance advice, etc. We do have a toolkit. And the last thing I want to remind you of is balance billing. So Medicare providers and Medi-Cal providers cannot bill dual eligible members for Medicare cost sharing, Part A or Part B. That's illegal. I will flag that for Part D prescription drugs, dual eligibles may still have a small copay, but basically duals should not pay anything for doctor visits, hospital stays, etc. if they're in Medicare, and especially if they're in a Medicare Advantage plan, a D-SNP, a Medi-Medi. If they're seeing a provider that's in network, they should never get a bill. Okay, next slide. So how does someone join a Medi-Medi plan? Well, they have to have Medicare Part A and B. They have to have Medi-Cal as well, and be age 21 or older. Of course, they also have to live in one of the counties where the Medi-Medi plans are available. But we do want to keep emphasizing that enrollment in the Medi-Medi plans is voluntary. And so to enroll, the individual can contact the Medi-Cal plan, and that same organization can enroll them in the Medi-Medi plan. There's also the 1-800 Medicare number, which can process enrollments. Next slide. Okay, next slide. Okay, so we at DHCS, of course, are really trying to get the word out. We do have webinars, etc. But if you have a specific question, please contact the health plan that you are contracted with or considering. Start there first. We do have a generalized inbox, info@CalDuals, but first thing is contact the health plan that you're working with. We have, again, a lot of information on our website. We have fact sheets, we have just all kinds of materials in various languages, videos, etc. And then you may have heard of HiCap. We have a strong relationship with them to make sure they've got information about Medi-Medi plans, and our Duals Ombudsman program, which is sort of the collaboration of local legal aid agencies. So they are also aware. We're keeping them up to date. Next slide. So this just gives you in a nutshell what choices a dual eligible patient would have in 2026 in Contra Costa County. They can have original Medicare plus a Medi-Cal plan. They can have a Medi-Medi plan for both Medicare and Medi-Cal. They could also choose a regular Medicare Advantage plan and a Medi-Cal plan, or PACE for those who need a nursing facility level of care. And we're anticipating that Contra Costa Health Plan and Kaiser will both have Medi-Medi plans available for enrollment for dual members in Contra Costa County in 2026. So open enrollment on the Medicare side is October 15th through December 7th. And that's when people who have Medicare can choose their Medicare plan that will be effective January 1st of the following year. So January 1st, 2026. Next slide. So what can you say? What might you want to say to your patients about Medi plans? So this is just optional talking points for your consideration. Medi plan has care coordination, one health plan card and one number to call for both Medicare and Medi-Cal benefits. So simplifies things, and again, access to better care coordination. There's those care coordinators. They can help the patient find doctors, make appointments, understand prescription drugs, set up transportation, follow-up services, connections to IHSS, other home and community-based services. And the last thing is, of course, enrollment in a Medi plan is voluntary. Next slide. And then we did this in Alameda County, and we got some very specific questions. So we talked to CMS, and these are the answers we got from CMS about what are you allowed to say as a provider to your patient about Medicare options. So you can share unaltered printed materials created by CMS, like Medicare and You. You can provide the names of the Medi plans that you contract with. You can answer questions about Medi plans, like cost sharing, benefit information. You can refer members to Medi plan marketing materials. Those have to be in common areas. We'll get to that in a sec. You can also provide information and how to apply for low-income subsidy. That's for affording prescription drugs. People who are dually eligible automatically get that, but you may have people who can just only want the prescription drug affordability. That's low-income subsidy. And then you can refer members to other organizations like HICAP or the Duals Ombudsman. Next slide. And one last caveat is that Medicare marketing materials cannot be shared in exam rooms, hospital patient rooms, treatment areas, but they can be shared in common areas like entryways, vestibules, waiting rooms, cafeterias, etc. Next slide. So again, we have a lot of materials on our website. Reminder to that the member can call the health plan of their choice or 1-800-Medicare. We have phone numbers here for HICAP. All right, next slide. Again, more materials. And in fact, we do have a webinar tomorrow, I think at noon. I mean, I know you've already just heard my, and many of the same slides will be presented tomorrow at noon, but if you want, there's a public webinar that the state is hosting tomorrow at noon. Okay, and I think that's it. Probably the next slide is questions. Yes. Okay.
All right, any questions for Anastasia? We can take them through the webinar chat or through the Q&A. So it looks like Frank Ma has a question about acupuncture, and then some specific questions about CCHP. Frank, what we'll do is we'll have our provider relations team reach out to you to get a better sense of how we need to answer your question. It seems it may be your unique experience, but we'll reach out to you. Diana Rodriguez asked, can you confirm the counties where Medi plan will apply?
Yeah, so Contra Costa is going to have Medi plans available in that county for 2026. If you want, we can go back to the map. Maybe that would be good on the slides. There you go. Yeah, so Contra Costa, Alameda, San Francisco will have Medi plans newly available for members to enroll in 2026. And then Solano, Napa, Sonoma, Marin will have at least one plan. May not have both plans yet in those counties, but at least one.
I don't see any additional questions.
I just
Oh, go ahead, Sarah.
so
I
I
just
just
saw it.
have one question. Just with regard to Contra Costa and KP being the only plans that will have these D-SNP plans. Currently, Kaiser does have Medicare Advantage plans. Will they have separate, like for their duals, could they potentially enroll in a D-SNP versus in MA with Medi-Cal that's not, linked as per the D-SNP?
Yes, so people, dual eligibles are not prohibited from enrolling in a regular MA plan like Kaiser. There are other regular MA plans in Contra Costa, but I don't want to speak for Kaiser, but I would guess, they have their own kind of marketing plans that they may use to encourage people to enroll in their D-SNP rather than their regular MA. But again, there are other regular MA plans in Contra Costa that people are already enrolled in.
Right.
And, again, it's voluntary, so they can disenroll from those plans or stay enrolled.
Thank you.
Mhm.
We have one more question. As providers, do we need to enroll in a Medi plan or is it automatic? If not, how do we do it? Could we still provide service to those enrolled in Medi plan?
I'll just quickly say, I bet that Irene is going to say, "Hey, come join our provider network." But if you may not be able to get reimbursed if your patient does join that Medi plan. So it's good to join the Medi plan network.
I'll piggyback on that, echoing what Anastasia shared. In order to see one of our D-SNP members, you would have to be contracted with our D-SNP network as well as our Medi-Cal line of business. Obviously, if a member is already established with you, as Anastasia shared, we do have to provide continuity of care, but that is for a limited time. Our contracting team will be sharing some information later in this presentation to kind of advise people about how to get contracted with us for our D-SNP line of business. We really do want to be able to offer our patients, your patients, our members, a comprehensive network. All right. I don't see any other questions. Thank you so much, Anastasia.
Thank you.
All right. Next slide, please. So, for those of you who don't know me, my name is Irene Lowe. I am our interim chief executive officer here at Contra Costa Health Plan. Previously, I'd been our chief medical officer, so I may have met many of you under those circumstances. Also, have been a provider in our community provider network for the last few years. Recently, stepped away from practice, but really excited to provide all of you an overview of our plan, our Medi plan here at Contra Costa Health Plan. Next slide. So our plan, as Anastasia alluded to, has its own name. We are known as Contra Costa Healthcare Plus and HMO D-SNP. This is an exciting venture for our health plan. We will be launching with the other Medi plans in January of 2026. And as Anastasia mentioned, it will be available to all eligible Contra Costa residents who have both Medicare and Medi-Cal. And what's really exciting is that it's a coordinated care model really designed to simplify the healthcare experience for your patients, our members. And it really does build upon what we already do at CCHP, which is have a very strong commitment to high quality and community-based care. And we cannot do that without our outstanding physician and provider network. So really it is a testament to how much you have been caring for your patients, our members. And of course, we will have a plan that will align with all state and federal D-SNP policy requirements. Next slide. So why this matters? It really does expand our role as a managed care plan. In addition to our Medi-Cal line of business, we will now be offering the Medicare line of business through our D-SNP. It pushes us to elevate our standards for quality, compliance, and service, and it gives us an opportunity to better serve our dual eligible population and improve the care coordination that these dual eligible members have access to and can receive. And it really allows us to deliver on our mission to serve the most vulnerable with dignity and excellence. and really also allows us as a health plan to increase our sustainability through through diversification of our lines of business. Next slide. Just wanted to kind of go over some brief high-level benefits for our members, your patients. It combines Medicare, Medi-Cal, and supplemental benefits like all Medicare Advantage plans. It provides a coordinated care team and care management support. Our members will have access to Contra Costa Health Plan's D-SNP provider network. We will also be providing, as part of our D-SNP, a prescription drug Part D coverage. And as Anastasia mentioned, we will be offering California Integrated Case Management for members with more complex needs. And as a reminder, it's basically very similar to what we offer for our Medi-Cal members, which is Enhanced Care Management, ECM. And through this program, we'll be able to offer intensive person-centered care coordination. We'll be able to focus on preventative care and member well-being. And our model of care, which we'll talk about later in this presentation, really ensures that the approach is person-centered and with high dedication to integrating services. Next slide. So just wanted to provide an example of someone who may be considering a D-SNP and ultimately joining our D-SNP. So I want everyone to meet Maria. She is a CCHP member who has turned 65, and she has been a CCHP Medi-Cal member for about 10 years. She has diabetes, congestive heart failure, and early stage dementia, and she visits multiple specialists and relies on her daughter for transportation. Today, without a D-SNP, Maria has Medi-Cal and Medicare through different systems. She receives conflicting bills and gets confused. Her daughter has to coordinate the appointments, and no one is really overseeing how her conditions interact or ensuring follow-up care. And she struggles with a lot of these ancillary services that might be provided by her insurance. So with Contra Costa Healthcare Plus, our D-SNP, as Anastasia mentioned, it's one card, one plan, and we will be one care team. And so all her benefits would be coordinated through CCHP, and she'll have a dedicated case manager who will help develop an individualized care plan and lead an interdisciplinary care team to ensure that her care is coordinated. And as mentioned before, she'll have one number to call, our member services line here at CCHP, to address both the Medicare and the Medi-Cal side of her D-SNP plan. Next slide. Also, there are benefits for you, our providers. We'll be able to offer members additional services. We'll be able to coordinate authorizations and services from both the Medicare and Medi-Cal point of view for our D-SNP members. It'll be single payment and claims processing, much more patient-centered approach to care, and it'll be enhanced collaboration with you, our providers, on care planning. And really, it'll be a collaborative approach and focus on prevention, quality, and outcomes. Next slide. So just the eligibility, which was shared earlier, members must meet the dual eligibility requirements for both Medicare and Medi-Cal. They must be eligible or enrolled in Medicare Part A and or Part B and must be able to receive full Medi-Cal benefits and, of course, live in CCHP's service area, which is Contra Costa County. Next slide. Just to kind of piggyback off a slide that Anastasia shared earlier, when we generated this slide, there were about 34,000 individuals enrolled in Medicare and Medi-Cal in Contra Costa County, and 24,000 of those individuals have their Medi-Cal with Contra Costa County. And our actuarials are estimating that by the end of 2026, CCHP will likely have about 2,000, maybe 3,000 members. So we're very excited to be able to provide these members with additional service. Next slide. Just wanted to share with everyone our progress to date. I will tell you that an application to become a D-SNP is a very, very complex and daunting task, and our team here at CCHP has done a lot of work. We've had our Part C and Part D applications conditionally approved by CMS. Our model of care was approved by CMS and DHCS, and we're very proud to share that we scored 100%. Our state Medicaid agency contract was also approved, and we submitted our bid, plan, benefit package, and formulary to CMS as well. And we are currently in the thick of provider and vendor contracting. And our teams, our operational units, are actively working on policies and procedures to ensure that we can lift this plan from an operational point of view. We also have our compliance team working on building a Medicare compliance program. And we have multiple cross-functional work groups actively engaged in readiness planning, not only from the operational standpoint, but also from the technological standpoint as well. Next slide. So this is our vision for success, and we truly cannot be successful without the engagement and the collaboration with our providers. So we're very excited to work with you on this new venture. Our vision for success includes a seamless, integrated experience for our members. We want to perform well and high on our CMS star ratings, and this is a testament to how well you take care of our members. So we do want to be able to support you in the care of your patients and collaborate and ensure that they're getting the best care that they can receive. And as I've already, shared, a vision to be successful, we have to have strong provider partnerships and clear expectations. We also have to have empowered staff here at CCHP who understand their role in the systems. That way we can provide answers and support to members and providers as needed. And ultimately, we want to have a long-term sustainable Medicare product for Contra Costa Health. We've been a Medi-Cal plan for a very, very long time. Our health plan itself has been here for over 50 years. So to be able to have a sustainable Medicare product would be, a clear feather in our cap. And so we really, truly want to succeed, and we cannot, again, do that without your support. Next slide. Any questions? Please feel free to place in the chat or in the Q&A. All right, hearing none, I'll turn it over to our next speaker.
Good afternoon. Thank you all for joining us today. I know I'm going to review with Lazel Avicilla our model of care that has been approved for our D-SNP line of business, and so I will address some of the components, and Lazel will address the care coordination components of that. And next slide, please. So what is the model of care? Model of care is just basically a foundational framework for guiding how our D-SNP, our CCH Care Plus delivery of all the services and benefits to ensure that all providers are aligned in delivering high quality and patient-centered care. And it's a requirement from CMS for all Medicare Advantage service lines. And it's essentially serves in our submission of the model care serves as our commitment to CMS, to our providers, and to our members who enroll on how we will provide care to them. Next slide. And so there's 4 big elements of the model of care. There's the D-SNP eligibility and population, which we heard a bit about from both Anastasia and Dr. Lowe. There's the care coordination component, which Lazel will review a little bit in further slides. There's the provider network element, and then there's the quality perspectives, which I will hand over to Beth when we get there. But essentially, next slide, please. The D-SNP eligibility and population is what we have reviewed, which is that you have to be full scope Medi-Cal and Medicare in order to be eligible. It does, as we went over some of the demographics earlier, you saw that it does encompass many of our most at-risk, vulnerable populations in Contra Costa, people that are eligible for both Medi-Cal and for Medicare, either because of age or because of disability. We do, as was presented earlier, see that a substantial portion of our duals are under the age of 65, so they are not qualifying into Medicare for the reason of age, and so really signifies that they have some disabling chronic illness or mental health condition. And there is a requirement in our eligibility and population to identify those members who are at highest risk by certain criteria, which will be part of our model care, such things as total number of prescriptions, utilization of high acuity services, such as hospitalizations or emergency rooms, and having certain diagnoses with chronic mental health conditions or with substance use disorder. And those, we are required to identify what is our high-risk population to receive that higher level of care management. So the CICM program, which is sort of the D-SNP equivalent to the ECM, as was discussed earlier. And that's part of the commitment around the model of care that will make this one plan with intensive care coordination across a spectrum depending on need. And I'll let, next slide, I'll let Lazel take it over for the care coordination piece of the model of care.
Good afternoon, everyone. As Dr. Levin said, I'll be focusing on a few key pieces of care coordination, of the care coordination part of CCHP's model of care. As you heard earlier, care coordination is such an important part of how we support our members and help them stay connected to the care they need. But what does this mean exactly? Next slide, please. First off, we start with the health risk assessment. To get a full picture of the member's needs, we use a comprehensive health risk assessment, or HRA for short. It helps us look at everything from medical and functional needs to cognitive, behavioral health, and psychosocial concerns. Members can complete this HRA in whatever way works for them. They can do it by mail, over the phone, or online through MyChart. We do the first HRA within the 90 days of when the member enrolls, and then we also check in at least once a year after that. And if there's any big change like a hospitalization or an ED visit, we can go ahead and do another one sooner. Once we have all of that information, we then use it to build an individualized care plan, or ICP for short, within 30 days of that assessment. And then this care plan helps guide how we support each member and make sure that the care team is aligned around the member's specific needs and goals. Now let's talk more about the ICP. Next slide, please. All right. The ICP is a comprehensive person-centered plan that's all about the member. It outlines their specific goals, specific problems, goals, and the interventions that we'll use to help meet their unique needs. We create this ICP using a variety of data sources, starting with the health risk assessment, but we also pull in information like utilization history, claims or pharmacy data, and any other clinical records that is made available to us. This gives us a very well-rounded view of the member's health and social needs. The care plan also addresses how we'll coordinate the care across the board, as Anastasia has mentioned earlier, with the providers, community agencies, external partners, and through Medi-Cal carved out benefits when it's applicable. The ICT, or interdisciplinary care team, takes the lead in developing this ICP. I know there's a lot of acronyms, but this ICT works closely with the member and their caregiver to make sure that the plan reflects their preferences, priorities, and circumstances. We update this ICP at least once a year, or anytime there's any significant change in the member's health or life situation. Once this is complete, we make sure that the care plan is shared with the ICT, the member, and any other key stakeholders that are involved in the member's care. Now that we have that clear care plan, it takes a team to bring that to life, right? So that's where the ICT comes in. Now let's go ahead and take a look at who's on this team and how well we work together. Next slide, please. The ICT is put together based on the member's health risk assessment, their identified needs, and their preferences. The PCP plays a key role in helping coordinate care and supporting any transitions in the member may experience. The core ICT typically includes the PCP, the CCH Care Plus D-SNP Care Manager, a pharmacist if applicable, a social worker, CICM Care Manager if applicable, and the most important one, which is the member and or the caregiver. Any other team members may also be added later on, like if there's a palliative care team member that needs to be involved, or any long-term support, long-term services and support providers like IHSS, CBAS provider, or any facility-based staff. The team works together to help make sure that the members' care is coordinated, person-centered, and responsive to the changes in their condition or goals. With the right team in place, it's important to do regular check-ins. One key component is the annual face-to-face encounter. Next slide, please. Oh, I guess I didn't. All right. Well, let me just give you a brief overview of the annual face-to-face encounter. Members are required to have a face-to-face encounter within 12 months of enrollment, and then at least once a year, every year after that. This encounter must take place between the member and the participant of the ICT. Most often is the primary care provider. These encounters obviously is very important in keeping the members' care member-centered, proactive, and aligned to the members' needs throughout the year. Apologies about the missing slide, but that's it for me as far as care coordination.
Great.
Thank you very much.
Thanks so much, Laisel. And then we do have, let's see, we got 9 minutes left. I will make us through this so we can get to the end of our slides. So model of care in terms of, the provider, I think the third component was provider network, and essentially Laisel went over a lot of what we're expecting from the providers in working with us as partners, really to the benefit of our members and your patients. And then with regard to the quality measurement and performance improvement plan, our quality improvement and health equity transformation program will enhance care for D-SNP members by addressing what we want to do is addressing their complex medical and social needs with high quality, safe, equitable, and culturally appropriate services. And through an annual evaluation and continuous improvement plan, our quality program and our quality work plan will assess for the effectiveness of our quality improvement activities. And this includes looking at things like addressing care gaps for our D-SNP members, our HEDIS measures with a focus on trends, the care quality, member satisfaction, and health equity that also looks at our member outcomes. That is essentially within our, the last element of our model of care plan. But to give you an example, like certain measures, which are very common in our HEDIS population, the breast cancer screening, colorectal cancer screening. But in terms of the D-SNP as this added element, a lot of what Laisel was mentioning in the care coordination piece are percent of members who have their HRA complete within 90 days and then have a subsequent ICT, the interdisciplinary care team, within those next 30 days after completion of the HRA. Those are all metrics that we will be following and will have to meet as we evaluate our quality activities within the model of care. All right, I'm going to hand it over to Beth for our last section. Next slide. Oh, sorry. There is a on our website will be an area for you to complete as the providers the model of care training and complete the attestation, which will be required as we roll out our D-SNP plan. And on that site, there's also other training resources and information for RCCHP Providers Network. Okay, next slide. Now,
Right, so there's
into the yeah, go ahead.
No, we have more time. I think this
Okay.
is scheduled until 1:30.
Oh, okay, thank you.
Yeah, we have a couple of questions in the chat. They appear to be about VFC vaccines. If we can take this offline, since this seems to be dealing with Medi-Cal specifically, we'll have our team follow up with you to provide that information. Any other questions? All right, we'll turn it over to Beth.
Hi, nice to meet everyone. My name is Beth Hernandez, and I'm going to talk a little bit today about marketing, sales, and enrollment. You can go to the next slide. Thank you. So these terms are ones we use a lot, marketing, sales, and enrollment. And I just wanted to quickly go over some nomenclature as we're going through, as this is very important with how we're talking about our marketing and enrollment information. In general, CMS defines marketing in a very specific way, in that it's content that's used to promote enrollment by highlighting things like benefits, costs, and comparisons, while sales is really about that process of trying to engage a potential member to get them enrolled in the plan. And both of these activities can only be conducted by individuals who are licensed insurance agents in the state of California. So marketing and sales can't be done by anyone. It's really it needs to be individuals who've received the proper training and have completed some certifications, both with the health plan and with the state of California. If you go to the next slide. So how do people enroll in the plan when they're interested? I'd say there's three main avenues in which people can enroll. The first one is through Contra Costa Health Plan. So CCHP will have some staff members who are licensed certified agents who can do that enrollment, and they can do that by calling our sales line. Those individuals, like I said, will be holding the proper licensure. And individuals can also enroll online when that is available through our website. We will have an online enrollment process. Individuals can also self-enroll through Medicare. So they can contact 1-800-Medicare to enroll, or they could go online to medicare.gov. And the third avenue is through the HICAP counselors that Anastasia mentioned. These are volunteers that work at our Employment and Human Services Division who are helpful in that they help people do plan comparisons and can do those enrollments. And so there's some contact information there. Next slide. So our enrollment timeline, what that looks like, we will start to be able to start enrolling individuals into our Care Plus starting October 15th through December 7th. This is what's called as the annual election period. And for individuals that enroll during that time, their coverage is going to start on January 1st. As Anastasia mentioned, individuals who are dual eligibles are able to enroll in Care Plus year round, and with their effective date being the following month. And so that is something that we will be working to try to spread the word about this to individuals who may be eligible. In addition, individuals who are aging into Medicare will have an initial election period. So this happens in the 90 days before they turn 65 years of age. And people who are going to be aging into Medicare can also enroll into Care Plus to be effective upon the time when they're aging in. Next slide. So what happens after enrollment? People will receive a letter verifying their enrollment within 15 days after enrollment. Prior to the effective date, they're going to receive a welcome packet, which includes their ID card. And then they're also going to be receiving a welcome call from individuals on legal team to help them complete that health risk assessment. Next slide. So some of the things that you might see as we're working to spread the word about our plan, we're going to be sending mailers and postcards to people who have dual eligible members. We'll be doing some phone outreach to individuals to let them know about the plan. We might be doing some tabling. We can do information sessions at some of your health centers or clinics or provider's office and at senior centers. And then we also have some flyers and brochures that can be left and provided in your provider's office. So here's just an example of one. If you go to the next slide. So as Anastasia talked about, what could a provider's role be in D-SNP? So I think there's some things that providers can do and that they can't do. So things that providers can do is display some of our previously approved materials in common areas. So like your lobbies or in the waiting room before people go into an exam room. And that has to be done after October 1st, because that's when we can start marketing in the plan, not before October 1st. You can always refer patients to our marketing team here to have them learn more about enrollment. We could be hosting a sales presentation at your office if you're interested in that to your patient population. And like Anastasia said, you can't answer general Medicare, Medicaid questions. Like, yes, we accept that plan. But what can't happen is sharing any of the benefit information before October 1st, so that it needs to be held until that marketing period begins. You can't use unapproved materials, so providers' offices can't create their own materials. It needs to be things that were approved through CMS, through CCHP. You can't help individuals complete those enrollment applications yourself. You'll either need to refer someone to our plan or to the HICAP office to assist them. Obviously, no offering incentives to join the plan, and you can't actively try to steer somebody to the plan. You should join this plan. Next slide. So just how you can help, I think if you're interested, we would love to host any brochures or flyers in your office and display after October. So if you have a small area for a poster or to hold a trifold, we'd love to let you know so we can get those in your office to let your patients know. Or if you're interested in having an educational event or presentation, that would be something we're also interested in. I think that's all I have.
Great. We'll turn it over to the next speaker.
Hello. Hi, I'm Elena White. Just wanted to give you some background around the provider contracting process. Next slide. Next slide after this one. So we have started outreach to providers that are part of our Medi-Cal network. So many of you have already received either letters of agreements or contracts in the past, or some type of information from the contracting team around the D-SNP product. These are some of the benefits of joining the D-SNP network with Contra Costa Health Plan. Several of these we've already kind of talked through already through our teams here. So growing your practice, promoting better care coordination, gaining access to dedicated resources, and also the quick and easy onboarding process if you're already part of our Medi-Cal network. Next slide. Again, this is just meant to be a brief what to expect. Our contracting team will be reaching out to you. I do want to point out, if you previously signed a letter of intent or signed a D-SNP or CMS Medicare Advantage addendum, you still will get a call from us to sign an updated agreement. So our teams will be reaching out to you, and when they contact you, they will confirm your practice's contracting point of contact to make sure that we have the right person, the email address and phone number of the person that we should be contacting and sending the contract to. We'll also be confirming the providers that are part of your practice that they're Medicare certified. And then the next steps after that is you will receive from Contra Costa Health Plan the D-SNP agreement, either a full agreement or amendment to your Medi-Cal contract, and that will be sent through DocuSign or through email. Again, the previous process, you had a letter of intent, or if you had an agreement before, it was the CMS required language. And even in those situations, you'll be receiving an updated agreement. So you can keep an eye out for that. And that will be in the next couple of weeks. We're starting to do outreach this week to those providers. And then we are asking that you review and sign and return those agreements within 10 business days. Next slide. And this is just our contact information on the next slide. If you have any questions, you can contact our contracting team. Again, you will have someone that will reach out to you, and we'll have details of your current contract and next steps, and they'll validate what the next steps are with you in terms of having someone reach out to your point of contact. And that's it. Irene, I'll pass it back to you.
Great, thank you. We just had one question in the chat. Is there a time frame in which we should be reaching out to CCHP contracting department if we have not been reached out to yet, if they've already signed an LOI?
If you are interested in participating, you could still send to our contracting team through email so that we can expedite. If you've signed an LOI, you will be at the top of the list for us to reach out to, as well as if you signed a previous agreement. So those will be getting outreach in the next week or so, but please do send us an email if you are interested, and we'll be sure to contact you as a priority as well.
Great, thank you. Any other questions? Please feel free to place in the chat or in the Q&A. All right, well, thank you everyone so much for joining us. I think that's our last slide. Great. Have a wonderful afternoon, and thank you so much for taking the time out of your busy clinic schedule to join us. Looking forward to working with all of you in this new adventure.
Bye. Thank you.